All right. Today I've been asked to talk to you very briefly about sexuality and cancer. So today I'd like to just cover some aspects on sexuality in regards to treatment and quality of life, and why I refer on it, and the use of the implicit model, which I'm sure that lots of you would know about. And this is because patients generally do not voice their concerns in this area, and they often prefer a healthcare professional to bring up the subject. And generally, patients would like more information that is timely and that's appropriate to them. So I think when there's a life-threatening illness like cancer, brings up huge losses, actual and potential, and we need these patients and their families need to communicate and receive love in a variety of ways that is true to them, and a desire for physical closeness and touch. And I think too, when we talk about sexuality in this area, not just about sexual functioning, but also about the concept of it being emotionally and intimately involved in who they are as individual people. There's lots of definitions on sexuality, and the World Health Organization talks about sexuality as being experienced and expressed through our fantasies, through thoughts, desires, our beliefs, attitudes, values, behaviours, practices and roles in relationships. And I quite like this one that I found a little while ago when I was presenting elsewhere, and I think it quite expresses how we could view sexuality and intimacy. And I quite like the last few words where it says the feelings of closeness and of being wanted and valued as a human being. There are many, with the different types of cancer therapies and cancer treatments, majority do impact on sexuality and on sexual functioning. And in Australia, more than half of all people diagnosed with cancer and treated for cancer will be treated and survive their disease. Sexual issues may persist for many years after the treatment, or even when the cancer has been cured. And one important quality of life issue faced is the alteration in their sexuality. The most common sexual issues that I hear about and work with patients is in the area of loss of desire and libidinous energy in regards to their sexual relationship, in the area for sexual activity, intimacy for both men and women, and the different phases, how this can impact on different phases of their sexual response cycle for men and women. It's an enormous area of concern, and I think, sadly, it's probably not always adequately or discussed or poorly discussed during time of diagnosis and at treatment. And body image and reproduction and reproductive health, sexual functioning, are three distinct aspects and interrelated to the aspects of human sexuality. And I think working with GPs at the Menopause After Cancer Clinic, GPs are in a good position to actually touch base in this area. This is a quote from an article that I was reading the other day, and it's talking about a nurse working there, sexuality, and Peggy has had head and neck cancer, and she obviously was upset. And the aspect that I never really thought about, even as a nurse in the younger days, is about how do we actually talk to patients in this area where her body image is so impacted in this regard, and having a nasogastric tube and then not being able to kiss your partner that you've been with, and then that anxiety of your partner potentially finding you not attractive, and it often is left unsaid. And just in a snapshot, there's lots of impacts in regards to sexuality and cancer treatments. Hot flushes, night sweats, sexual difficulties, sleeping difficulties, and tiredness can be extreme. And this is particularly so in younger women who go through an earlier menopause or who undergo a surgical menopause as part of their cancer treatments. And I think too, it sometimes can be difficult to disentangle the effects of treatments such as chemotherapy from menopausal symptoms as well. And infertility adds to the burden of treatment for women and men. In a quality of life study of 48 men with erectile dysfunction after treatment for early prostate cancer, quality of life was significantly affected in the following areas, which I found quite interesting in a couple. The quality of life of sexual intimacy obviously was obvious, but everyday interactions with women was affected, sexual fantasy life, and the perceptions of their masculinity. And resuming sexual way of being and their sexuality is a way of feeling normal and returning to a sense of normality and increasing their, encouraging their well-being as well within relationship. And when you look at all the changes, and these are just not exclusive, they're just a list of some, they all can impact on the individual and obviously the consequence within their relationship. And even if they're single as well and wanting to go into a new sexual relationship, it can be a huge burden to bear. So I'm just mentioning a couple of things, particularly for women. Dyspareunia and vaginal dryness are probably the most common aspects that I hear about in relation to cancer treatments. And often too, I think it's really important just to identify what is actually happening, because sometimes it can be just as simple as having a vaginal dryness, which a simple personal lubricant might be helpful, or it may be something more, particularly if they're menopausal. The pH changes, as we know, in the vaginal area can cause bacterial infections, burning sensation like vulvodynia, or not uncommon, I've seen quite probably half a dozen women who've actually developed vaginismus due to painful intercourse and have left it for quite a period of time. And I think too, you know, simple things of like discussing with them the use of personal lubricants, because even sometimes some women will actually sort of feel uncomfortable suggesting this within relationship, particularly if they're younger, because they've never had to use it, and they think about the impact on their partner, thinking, well, it means that maybe I'm not actually arousing her enough, or she doesn't find me sexually attractive enough. And sometimes I have to really encourage women to try out the actual personal lubricant to begin with. And sometimes it's not unreasonable to try some vaginal estrogens locally if it's not contraindicated, because that ideally helps, particularly in the area of the vaginal atrophy. This is just a comment from a patient. You know when you go through your PowerPoint and you find a typo? Just annoying, but it says, I was having trouble with hot flashes and vaginal dryness after my chemotherapy. So I decided to ask the intern, the female intern, about how to deal with this. And when I told her my problem, she said that she would order some eye drops. That should be for my eyes. And you know, even though that's quite extreme, often doctors minimise the impact of the treatments on their sexuality, and I think sometimes women in the area of breast cancer will probably stop taking their hormonal treatment, approximately about 25% would, because of the impact on quality of life. And particularly for younger women, they're more vulnerable to psychological distress, decreased sexual functioning in relation to the menopausal symptoms, and also in relation to fertility as well. For men, really important, I think, in practice, to have a discussion about what can be helpful when there is erectile dysfunction. And also, just some conversation, often men are not informed that sometimes there's absence of ejaculation, going back into the bladder as well, which they find unusual, or there might be urine in the ejaculation. And I've had someone come and talk to me about that, and they were just wanting that information because it wasn't really clearly explained to them during their treatment after their prostatectomy. And sometimes there's pain during intercourse as well, and changes in the sensation in the genitalia area because of chemotherapy, and obviously because if they're older as well, we know that life stages can impact on time to arousal and orgasm as well. And you know, I think even using the PDE5 inhibitors can be useful, but sometimes that may not be enough. Sometimes even having all that, there may not be the desire or the energy to actually manage the erection. And I had a patient who had melanoma, metastatic disease, and he said he had no energy, no libido. His wife was getting quite distressed, and they didn't know what to do about it. I went to see them, and in taking the history, I noted that he had a low libido for many, many years and used to have testosterone injections. And that was something I thought, well, is it possible to have that now? And they didn't think about that. And obviously the impact of his treatment was making him more fatigued. And we were able to get the confirmation from his oncologist to say, yep, that's a good option, it won't interfere with his treatment. And he was going to go off to his GP to have that conversation and get his levels checked. And also I think when talking about sexuality, and in my practice, I often talk about it in regards to sexual health. So if they're not in a relationship but they want to be sexually active, is using condoms as well. And sometimes the non-latex condoms, for example, can be more less irritating and easier to use. And if you need to use it during chemotherapy, for some people, we had a gentleman who had a younger woman who wanted to remain sexually active for her, and we spoke about the use of condoms to prevent, as a barrier protection during his treatment, so it wouldn't impact so much on their relationship as well. Partners are really experience the ripple effect from the disruption in their partner's cancer and diagnosis, and this in turn can decrease their libido. And much apprehension is there in regards to the initiation of sex and the fear of rejection or being hurt. And it's not uncommon to see women and their partners not having sex for months, and then the assumptions that are made, because they don't talk about it either, that they don't want to have sex or they're going to reject me. And there's such fear and anxiety behind that for both couples, both partners. And the complexity of regaining a sense of normality within their sexual relationship and a feeling of a sense of being unwanted or undesirable by their partner because of the lack of or the ceasing of having sexual intimacy, which is quite common themes. And what's really interesting is that less than 20% of partners of cancer patients are able to renegotiate their sexuality within that relationship. So it means that 80% approximately are struggling in this area. And 84% of partners of women with a reproductive type cancer report a negative outcome in their sexual relationship. And this is ongoing. So I see people like 5 or so years down the track. And this slide's just about sexual diversity, and I think we're all aware about the diverseness in sexuality and our own assumptions and biases that may come up when we talk to patients about their sexuality as well. The impact of our cultural beliefs and whose domain is it to talk about sex, because often the buck gets passed to me, which is fine because I'm happy to talk about that, but sometimes they don't get to see me till months down the track. So I think it's really important that we think about our own thoughts in this regard, and also we at times underestimate the values and the opportunity that we can have to talk about sexuality intimacy with their healthcare professional. I like this one. I just took a leaflet out of my mailbox informing me that I can have sex at 82. I'm so happy because I live at 73, so not too far to walk home afterwards. Okay. This slide is just to remind us that sexuality is not just physical, and I think we know that the greatest sex organ apparently is the brain, and it's so true. And I think with men and women following their cancer treatment, where they don't have the spontaneity or the physical changes, part of my role is helping them to enhance their thoughts and their feelings and looking at how they see and view sex, because sometimes they have to change their repertoire or add more into their sexual toolbox to make it fun, to enhance the libidinous energy and that connection. And I think too, when you talk about lubricants, often I've had women who still use KY jelly, which, not that I can't not recommend, but it's not the best one to use, and sometimes using Vaseline. And we know that that's actually quite disruptive to the vaginal mucosa. So if they can use quite a good lubricant that is going to be helpful, it's going to make all the difference. And my fundamental book I use is Good Loving Great Sex by Rosie King. Do most people know about that book? It's great, and it talks about relationships and sexuality, and it just gives people a basis to start from when they have to renegotiate that as well. This is just to say that older people are still doing it quite a lot. Okay, the last bit, do people know about the implicit model? Yeah? Okay, so basically a report, the reason why it's so important to do an assessment, and we all know this, but just to remind you, is that the Journal of American Association revealed about 3/4 of people surveyed believe that their health concerns would be dismissed by their doctor, and nearly 70% thought that they would embarrass their doctor if they spoke about their sexuality and their sexual needs. And I think often women have a strong desire to talk about it, but they don't because they feel they're going to be rejected. And this is just giving permission, limited information as we go along, specific suggestions. And in all of that, it just helps you frame it within your practice, and we ensure that patients are referred on to the appropriate resources and entitled to the care that they need, and often assessing their understanding and their knowledge in this area as well. And also to remember to follow up. So we know then, as part of the conversation, that you are able to do an assessment at time of diagnosis and throughout that treatment, even into palliative care. You'd be surprised the number of people who are in palliative care who want to know about their sexuality and how to enhance it in that area. And I think, whoopsie, I've gone too fast. Can I just go, oh, no, I'll keep going. Because apparently, with intervention, 70% of patients have an improved functioning in sexuality. And this is one I talk to patients about because we talked about touch in the previous talk by David. We know that it's important to have fun, to take the pressure off, because sometimes there's some medical interventions that have to happen before they can get back to sexual activity. And knowing that sexual activity is just not about vaginal and penile intercourse, it's about other aspects of intimacy as well. And just having fun in that regard. And I just have a couple of slides on resources that you're most welcome. I think you're going to put it onto the website. And that's probably about it.